Welcome to this episode of The Compliance Guy. We are live. It is 12 o'clock here on the East Coast on Monday, August 7th of 2023. We have folks that are in the Central Time, folks that are in the Pacific Time, and we have folks that are across the international date line. So with all that said, we want to say welcome to each and every single one of you from around the country, around the world, wherever you are. Today we have a fantastic lineup of topics. I always worry that when we have two or three topics, we may not, we may finish early and somehow Terry just starts yelling at me about something and we wind up going right till 12 o'clock. So with that said, all of my friends, with the exception of Stephanie, are here today. Paul Spencer, Scott Kraft, Christine Hall, Terry Fletcher, and Stephanie, if you are hanging out and listening on your ride over to Vanderbilt, we wish Jesse well. So, all right. So let's kick this thing into high gear. I think the first thing that we want to talk about today is a topic that Christine raised, and that is adding information to your medical records after you have been put on notice of an audit. So I'm going to zip it. I'm going to let Christine kind of take it from here. And the floor is yours, my friend.
Well, thank you. So I have been struggling lately with a hypothetical group that may or may not be reopening their closed notes to justify a level of service that was originally not supported. So, not for clinical purposes, not to say, hey, I got lab results back and the patient has this concluded diagnosis or definitive diagnosis, but it was a level 2 and I'm adding more information to make it a level 4. And I completely just couldn't understand how anybody would think that is remotely possible to do. So I've had to have a chat with them. Yeah. So Terry, have you had this experience before too?
I had one actually was even cooler. I like when I say these things where you guys can't possibly think this could happen because then Paul gets a look on his face like, oh my gosh. It's just like, and Scott's like, oh, I've seen that, and then we've got Sean that's just like, yeah. So I had one where um, the payer actually asked me to, audit some records for this provider, and they weren't meeting a level 5. And so I'm looking at all the records, and then I contacted the provider as they asked me
Everything
to.
wasn't a level 5, Terry?
No, it wasn't. It's
Sure.
amazing. It wasn't even hitting a level 4. So I
Hmm.
contacted the provider and I said, I have your records, and these are definitely not a level 5 or anything, and they're not even hitting moderate. And he says, well, let me send you what I have. And so his records for the exact same date of service, same patients, were different. And I said, why is this different? He goes, because sorry, it's not funny. After I got the notice for the audit, I went in and changed them. Okay. You guys ever seen that meme with Shirley Temple kind of laughing? And people put it on sometimes, when they're just like, I can't believe this is happening. And I said, you did what? And he says, I went in and changed it. I wanted to make sure it hit a level 5. So I went in and added something. I mean, he just kept bearing himself. And I was just like, what kind of things did you add? And he said, I already knew. He goes, well, I added that there was more tests run and everything. I go, did you order those tests? He goes, well, I'm going to now. I want to make sure it gets to a level 5. And we just kept going. Yeah, see, Sean, Paul just even couldn't even shake his head. It just went right down. So
It gets better, and by better I mean worse.
even worse, exactly. So after talking through with the provider and saying, you can't do this, you can't do that, and you're going to be sending some refunds, he kept arguing the fact that this doesn't make sense. It doesn't make sense. If I can make it a level 5, why can't you just let me have the level 5? And I'm just like, it seemed to a practice that they call me, and I'm sure they've called all of you for education. They say, can you just educate on how to get my doctors to understand what a level 5 is? I'm like, no, we can educate them on E&M and give the spectrum of what you can bill for and how each individual level of service works, but I can't just tell you how to upcode. So I'll throw it back to
Isn't
Scott.
that the way it's supposed to be, though, Terry? Like some visits are going to be a 212, some visits are going to be a 213. It's just what does it present today?
I
How does it
learned
look
growing up in West Philly.
Yeah, it just, I don't think people understand there's something called addendums, late entries, and corrections. And this is something you can do with adding it before it's billed, before the records close, before it leaves the office. Because remember, once it leaves the office, and and it's billed out, there's a record of it somewhere that doesn't include these extra things. And now you are changing or altering your medical record, which is not a legal thing to do. And I'll throw it to you guys, see what you guys feel about that.
I think I always tell them, Terry, that it's okay to do it for clinical reasons, right? So again, you got the test results back, you spoke to another colleague, you reviewed some information, and now you've got a definitive diagnosis that you're working with. You're changing the plan of care based on that information. But to try to either support a certain level of service or bump it to a level of service by adding irrelevant information. I spent X amount of time with the patient to try to shift it from MDM to time base, or maybe there's a blurb that's added that I went in and I read the plan of care and I agree with the nurse practitioner, like things like that, it's very clear to see you're adding that to alter some payment of some sort.
Right. And adding it as a new entry and for additional information that wasn't available before is one thing, but to change a record, to try and alter it, to make it something that it isn't, that's where the problem is really going to come up to kind of get you. Scott, have you seen that?
That's right.
Yeah. And in fact, one of the questions I'm often asked when I'm doing education related to my own internal audits, this is not even a payer audit at this point. This is, I'm auditing on behalf of the client. I'm doing the provider education, and the provider will say, well, how about I just go in and add some things? How about I just go in and change some things now that you've told me the reason that this is not, a level 4 or a level 5. I can say it took a certain amount of time, and I sometimes, when the provider asks me, what do I have to do to make it a level 5? There's this part of me that's like, well, if you grab a lead pipe and you beat the person up a little bit, you might be able to get it to a level 5. Like, it's just not a sick person. And so, I think as an educator, one of the things I'm always trying to be thoughtful about is what are the genuine missed opportunities for the provider, right? Like sometimes a provider will say to me, well, I this was a complicated patient. I had to talk to the cardiologist, and I look in the note and I say, well, you didn't say that in the note, and we can credit that as part of the data complexity component. So it's understanding, did these things actually occur? But this notion of stuffing the documentation or saying, well, now that I realize you're telling me this isn't a 4, I can go in and say it took me 30 minutes or do any of those things. I get asked that quite a bit, and it's a real slippery slope just in terms of, as I say to providers sometimes, if every patient was a level 5, they wouldn't have bothered with levels 2, 3, and 4. Like, I mean, I hear that more in the inpatient setting, right? Well, these patients are very sick; they're in the hospital. I'm like, I get that, but 99222 like is a code that does exist that also explains people who are in the hospital, as does 99221. So the short answer is I'm asked that quite a bit, and I think internally, it's really not something that you want to indulge even before you get to an external payer audit. This idea that you're going to go in, identify things on audit, and then rather than make amends with the payer, the provider is going to go in and fix it. I don't think is a good idea.
Well, and I think you have a problem too when people are looking at it as the complexity of the patient and not the complexity or the high risk of the encounter. And you have to really get that mindset changed since the 2021 rules changed.
Right.
You can, I mean, how many times do we get oncologists or pulmonologists or even cardiologists saying, well, because I'm this kind of doctor, all my patients are complex. I'm like, well, they may be complex, but when you have a encounter today that says patient stable, doing well, improved, yada, yada, yada. And you just keep saying how well they're doing. Good for you. It means you're a good doctor. It's working. They're, adhering to what you're telling them to do, and they're now getting their goals met. You're not going to get to a level 5 just because they're a cardiology patient with 2+ chronic conditions. It
Well,
means that, you have to look at today's visit. What is the plan today? Hi,
and,
Christine.
and frankly, I mean, I'm trying to think of a good way to say this, but with respect to the complexity, sometimes when the providers say those types of things, I've sat with cardiologists who basically will say to me, I see these people all day. Like the complexity, it's not complex to me, right? Like the person is ill at a various level, and sometimes that's a different conversation around, in some instances, I'm telling them that what they've documented supports a higher level of service than what they've coded. It might be like a 4 versus a 3, and the provider doesn't see the complexity that way. So, I don't want to second guess or question the providers in those situations, but when you're seeing the same condition and you're managing the same condition day after day, it's hard to argue, well, this is wildly complicated for me as a provider, and therefore it should be a higher level of service, because it's just not always the case. And even if it were, the complexity, to Terry's point, does really relate to the patient and what the patient needs, and that specifically is a change under these guidelines.
Well, my favorite
Well,
change under the
go
guideline
ahead.
is, sorry, the new guidelines for inpatient, because for as long as I can remember, going back quite a few decades, you had those providers that were in the hospital setting. It was a 99223, 99233, 3333 discharged home. And I don't ever believe that that was really demonstrated in the documentation or supported in documentation. So this year, when we had those new guidelines that came out that said, yes, they still require hospitalization level of care, but they're getting better. They're getting stable. My friend Pam said at one time, so we would not expect a patient to be that 223, 233, 233, 233. Did you send them home to die? We hope they're getting better, and that we would see that in a normal encounter. So you would see that 233 to a 222, or maybe a 221 as we get ready to discharge, or 231, sorry, as we get ready to discharge that patient. You could see that natural progression happening there.
Well, two things. Just following up on what Christine had to say. I mean, I remember the days with handwritten notes. Looks good. Ate breakfast this morning. We'll discharge tomorrow. 99233. At least we're beyond that.
Critical care.
What I'm seeing in after the 2023 guidelines, particularly in a hospital setting, is the over credit of the data element, because they're not really getting paid for data. They're getting paid for review of that data. So I would watch that. I'm also seeing a pattern of hospitalist groups who are at the mercy of the EMR system that the hospital has to say, and it's kind of designed to just carry forward, and not really make a unique visit out of that. And just one last footnote on 99215, another area where I see abuse of that is in workers' comp. And it's a sin of omission more than anything else, because we know that workers' comp visits, in some cases, depending on the specialist or depending on who's seeing the patient, that can lead to a lot of paperwork. It can lead to a lot of follow-up with other specialists. It can lead to discussions with the patient. It's important to document all those activities, and that goes for any E&M service where you're trying to credit time for the level of service. You've got to document exactly what you're doing. And it used to be that way when you're doing more than 50%, blah, 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 and you had to put together some type of narrative to explain how you were using that time, what care coordination you were doing, what counseling you provided. Really hasn't changed. But it's a lot more detail now when you're trying to bill by time.
Well, and I would just say a couple of things to that. Like, one is, I'm still looking for them to do, as I describe it in my reports, to account for their time in a medically necessary way. Like, why was this 50 minutes or 40 minutes or whatever that was, when the visits look fairly the patient's recovering, right? I'm like, I don't understand like why this took 40 minutes. And the data, just to circle back to that for a second, I mean, in terms of leveling out services, particularly in the inpatient setting, but I see it in the outpatient setting sometimes, the data is a real concern to me in terms of, I spoke with the cardiologist about the patient, and you go and you look at the cardiologist note, and the cardiologist had maybe signed off 2 days earlier, and you're kind of wondering what's happening today and what's not. I recently had a psychiatric case I looked at where the provider had documented, I reviewed the labs in order to assess the patient's whether any physical difficulties were impeding the patient's psychiatric condition. And this note was from June of 2023, and all of the labs in the note were from June of 2020. And I, and I'm like, absolutely not. like if you could tell me how a 3-year-old lab gives you any insight into this patient's physical condition, when one, you chose not to reorder, nobody chose to reorder, nor did you comment on it. And I think those are some of the bad habits of these, I mean, getting off track a little bit from the higher level of coding, but it is related in that I think these are some of the concerns related to the new guidelines in terms of how they're impacting the code output and what is ultimately defendable. Because I mean, I see that all the time with hospitalists trying to scratch their way up to level 3, and I'm just looking at all these x-rays and all these MRIs and EKGs, and they're not talking about it in the plan. I don't know if they're reading it, other than they have a template statement in the thing that says, I reviewed all the labs. And sometimes it says, I reviewed all the labs, and you look and there are no labs, right? So it's sort of a canned statement.
Yeah. So, I want to go back to the original thing that we were talking about just for a moment, which is the falsification of the documentation, right? So, depending on the level and how it is interpreted, right? If it is deliberate falsification of a medical record, it could actually rise to the level of a felony. Um, Here in the state of Georgia, where I'm from, falsification of medical records is a misdemeanor, which I have a hard time with because I feel like that's an intentional misrepresentation and it can be used for enrichment purposes. Now, granted, a lot of these matters don't get handled at the state level unless it's a state funded plan or a commercial insurance company. But, the federal government will intervene. And I can tell you that's where these things move into um, felonies. And, you got to remember a couple of things, right? First, falsifying a medical record is without a doubt a crime that's punishable either by a fine and even jail time. Again, altering medical records makes it harder for doctors to be able to prevail in a false claims case or in a healthcare fraud statute case, or even worse, in a medical malpractice case. Um, Second, and this comes from somebody who spends and has spent an exorbitant amount of time in federal court. Um, Juries don't like liars. They don't. Juries don't like liars. Trials are about credibility. It's about who's the most believable, who has the most compelling argument or compelling story. And once a prosecutor or once a defense counsel or once an expert witness or a fact witness is shown to be not trustworthy, that can play significantly against one of the parties. So there are times where Paul, Scott, Stephanie, and I are working on appeals for clients, right? We have a client right now that their appeal is actually due back to the MAC today because we're trying to prevent this provider from having to go to round 2 of a targeted probe and educate. Now, we adamantly disagree with the auditor, the nurse reviewer in this matter, right? And as a result, we have encouraged the provider to add clinical summaries to the documentation, right? These are not addendums. These are not late entries. These are not corrections to the medical record. These are clinical explanations to help individuals who might not necessarily understand this specific specialty to the degree that you would hope one would if they are auditing it, to help them realize why the provider is ordering or performing certain services and or tests or procedures in the way that they are. Last week, I had to do a proffer with an attorney with the Department of Justice, and it was mind-boggling to me speaking with the prosecutors and the chief of the division, just how limited their knowledge on these things actually are. So creating clinical summaries is a great way to help somebody understand a provider's thought process, to help them understand their clinical judgment without being accused of altering the medical record. Because again, once you have been notified of audit, you cannot adjust or manipulate in any fashion your medical documentation. So let me pause there. Christine, I think you had something you wanted to add.
Yeah, the other thing when we're talking like on the roundtable, I get a lot of providers that say, "Yeah, Christine, but I'm just a small doctor over here, 15 providers. I'm not the big guys. Like that's who the feds go
That's
after."
not a small provider.
Well, I tell them all the time. I said, "Do you not realize that there's probably, in a 10-mile radius, there's probably half a dozen people that are on corporate integrity agreements, but they don't call the news and say, 'Hey, by the way, I got in trouble. I'm on a corporate integrity agreement. Can you come do a piece on me so that everybody in the community knows that I got in?'" Nobody does that. Nobody airs their dirty laundry. So you're not going to know that your neighbor got in trouble for something, or that an independent doctor down the street, or a large conglomerate for that matter, maybe they settled to not have something so public in front of them. So those providers that are under that misconception that it'll never happen to me, oh, it's not a matter of if, it's just a matter of when.
Yeah, and the thing to keep in mind, right, is nobody in the government cares about what size group you're a member of, because they don't look to go, "Oh, here's a 5-doctor group or here's a 5,000 provider group." They look at individual NPI numbers. They do everything based on data analytics. But let me just quickly give a couple of examples, if I can, of what would be considered examples of falsifying records, because some folks may not realize this and they may think it's okay. So obviously, I'm going to start with the duh. Yeah, we get that one, Sean. But creation of a new record when records are requested. That's exactly what we're talking about. Backdating entries, post-dating entries, pre-dating entries, writing over or adding to existing documentation except as is described in the section of the Medicare Program Integrity Manual. I believe it's chapter 3, 3.2.3.5, if I'm not mistaken, which is late entries, addendums, and or corrections. But I'll give you a great example, because pre-dating entries. So last year I was in the hospital, and it's this one practitioner who was doing it, right? And the doctor, the attending who was taking care of me came in and said, "Hey, I see that cardiology was already here this morning." And I'm like, "I have no idea what you're talking about." He's like, "Well, there was a note already written." Hand to God. There was a note already written that so and so was already here to see you, and that they discussed with you what they wanted as, the plan of care while you're here in the hospital, which included a cardiac catheterization. They wanted to do some other stuff. And I was like, that's news to me, because I've not seen anybody from cardiology. So I didn't say anything, and I asked the attending not to say anything. Do you know that he saw me at 9 o'clock or 9:30 in the morning? It was 4:30 in the afternoon before this practitioner from cardiology came in to see me. hadn't even examined me, hadn't asked me the first question, hadn't gone over any of my troponins, hadn't gone over any of my other stuff to share with me what their process was for how they arrived at, we're taking you for a cardiac catheterization. And when the individual came in, I said, "Hey, let me ask you a question. I understand that you created," and went through the whole thing. And the provider said to me, "Well, I knew what we were going to do." And I said, "Well, how do you know that I was going to be in an agreement with any of that, considering that I had a cardiac catheterization 6 months ago?" Sorry, that's not happening. Now you have created a medical record that you're going to have to go back and you're going to have to explain why you're creating a correction to the medical record, which is, oh, I never consulted with the patient. I just simply, in my own mind, decided to create a note before I ever saw the patient as to what I was going to do. No, it doesn't work that way. Folks, you got to be smart about this stuff. Seriously.
Yeah. I have an example of the reverse of that, where I had a doctor create a note for 2/6 2 days later, and labs from 2/7 were blown into the note. Which that's incredible prescience on his part, but it's if somebody like me can find it, best of luck with a government auditor or an SIU.
I mean, I did a review last week where the provider had a note for an admit. Date of service was the 22nd, and I still haven't done the education yet, so I don't know the mechanics of it. But I saw the exact same note that had been created on the 21st, and then repeated on the 22nd, which was what they billed as the admission. And I don't really know how that came to be. I'm going to find out maybe at some point. But I don't know. And I think one of the interesting things about Sean's experience, and I do see this sometimes in the audit work that we do, is the payer will reach out to a patient and interview them about what happened. And, some of these things that I see in notes, I mean, we always used to joke about under the 95 and the 97 guidelines. I always used to say, I'd love to put the doctor onto the lie detector test and see if he did this 10 system exam every single day that was in the note. And a lot of that stuff is still in the note. But if they go and they ask the patient, did the doctor do a head to toe exam of you? Did this happen? Did that happen? What is the patient going to say? And patients are not always the most reliable relators of the nuts and bolts of these encounters. But, I think what I would say to a practice of any size is you do not want, you don't want the letter V and a period and your name on one side and United States of America on the other side. And so you really do not want to be antagonistic with these rules or, any of this, like, well, I'll just fix this in this way, or I'll just fix this in that way. Really should just be focused on documenting to the level of care you're providing and billing for that work.
And here's the last thing that I'll say, and then I want to move into Terry's topic, and I'll give Terry the last word on this one.
Okay.
Folks, here's the other thing that I'll share with you. If you are behind a week, 2 weeks, a month, 3 months on your documentation for patient encounters, there is no possible reasonable way on God's green earth that you're going to be able to create accurate medical records. Besides that, CMS in chapter 12 or chapter 15 of the Program Integrity Manual specifically states that patient medical records are to be completed within 24 to no more than 48 hours after the patient encounter. Some of the MACs are explicit in that even if you don't have all the information that you need, you have to close your notes, sign them and date them, and then as appropriate, you can add an addendum, a late entry, or correction to the medical record if necessary. Do not try to create medical records beyond the reasonable period of time, which for CMS is 48 minutes. All right, Terry, let me give you the last word because I think I stepped on you for a second, and I apologize.
No, that's okay. I probably stepped on you, as usual. I think the one thing too is I just wanted to bring up is one thing that's being audited like crazy right now are telehealth encounters. And all see things. Remember, you still have to have a medically appropriate history and exam. And in the exam, it's limited because you are virtual. And I'm still seeing things like when we palpated the mass, how'd you do that? Or I'll see vitals. And if you actually look in the 1135 waivers, you can only allow the vitals if it's by FDA approved devices that are taking the vitals. You can't just go by, unless you say verbal by patient their weight is, but then you can't count it towards constitutional. It's very clear, and people didn't even see that in the documents when it came to the direction on that. But I'm seeing these unbelievable days that don't make sense when I'm looking at the telehealth. And even now, one of the things, I have a very big payer that's saying, okay, we've got 1,000 records we need you to look at. The way we're reading the E&M rules and the way the doctors are doesn't make sense. And this kind of speaks to Scott's point on data, where they will order a test, order, diagnostics, whatever, and they say, we're going to schedule a telehealth appointment within 2 weeks to go over your test results. No, that when you can't do that in most cases. Now, I'm not going to say never, but to just give results, you already got paid when you ordered the test. But let's say that the patient, they're suspecting, let's say, lung cancer, they order an MRI, and they did not, now you can do that independent interpretation. But on the return telehealth, if it's in depth discussing how to move forward with their plan, what are you going to do? Is it oncology? Is it surgery? All that. I tend to look at that as a medically necessary visit. But just to give results from something you ordered because they want to leave the office and you don't have the staff to basically call them with normal results, you can't do that. And this is becoming such a huge issue with commercial plans. Medicare eventually will get on this soapbox too. So just be aware, you've got to be careful when you put things in a note that doesn't make sense. How can you virtually touch a patient? You can't. So you have to only say what you did. And that, again, going back to everyone's position, when some of this information is brought forward, it doesn't make sense sometimes if the visit isn't in person. And so you have to review it. And I'm even seeing some of the AI practices now that are using AI where it hallucinates and puts words in that actually the doctor didn't say. And again, my favorite one is from, instead of ruptured Achilles, ruptured spleen. I see this like all the time now. It seems like it's an AI mistake that nobody seemed to fix. Talk about a difference in treatment. if you're told you have
That's right.
from a ruptured Achilles to a ruptured spleen, oh my gosh. I had one that the
That's
doctor
right.
says, I documented diarrhea and it put in diabetes because of the first 3 letters. And I'm like, oh my gosh. So being put on metformin for diarrhea. Okay, awesome. Okay, Sean, it's
It's
all
gonna
yours
say
now.
that's
Let's go.
an interesting treatment
Okay.
plan.
I know.
Yeah, I'm actually going to leave you in the big box for a minute, Terry, because I want to shift to diagnosis problems.
Okay, good. Here we
And
go.
I think we're on track. Your segue was a perfect lead
I'm
in.
comic
So let's
relief
talk
sometimes.
about let's talk about what Aetna and several of the other payers are doing
Okay.
with denial of diagnosis. And then let's talk about the different types of diagnoses that
Okay.
are critical to, not only reimbursement, but accuracy of the medical records. And I think really today's show centers all around best practices for documentation of the medical record. So
Right.
let's keep with that theme.
Okay, so we've got a problem right now with one of the bigger payers, and it's Cigna, and everybody knows because they're causing all kinds of problems. And I think number 2 would be Aetna. But there's a lot of denials right now for using unspecified diagnoses. Now, there's a time when unspecified diagnoses are appropriate. There is a time, but when it is unspecified, when you didn't put in the specific laterality, that's usually not appropriate. So if you should know if you're working on the right or left side of the body. Let's face it. But there are things, like iron deficient anemia, things like that do have an unspecified status. Just putting in anemia blanket is really tough because you need to have something that has proof that they have it. But what's hard is that I think that billers, collectors, people who are on the back end trying to get these claims paid, you need to know there's 2 different things. There are unspecified diagnoses that are valid, and then there's covered diagnoses for the particular service that you find on local coverage determinations, national coverage determinations. Now, we use those as guidance. The problem I'm seeing is a lot of practices right now are using the LCDs and NCDs saying, well, let me just pick a diagnosis on here so I can get it paid, when they don't have confirmation of that diagnosis because they're seeing the unspecified getting kicked out. So we've got a mess because sometimes, again, the unspecified is appropriate, or the doctor says, I need to have this. For example, they're doing an echo to check the patient's valve situation and what's going on with that patient's EF because they've been on chemo so long. Well, medically indicated, yes, but is it covered? It may not be. And so then you'd have to have the patient sign a waiver. They have to know that this may be their responsibility. But I'm going to defer back to everyone else on this. There is a stigmatism or a problem or a stigma or whatever you want to call it, that I think everyone, and mostly providers, think that every single thing should be covered, and it's not all the time. You've got frequency guidelines, you've got diagnoses linking, you've got non-covered services. I mean, they're just out there. And just because you think that diagnosis is appropriate, it doesn't mean it's going to be covered. And unspecified is a problem. If you can get as specific as possible, that's really helpful. But you're going to have to do some due diligence here, and I'll throw it back to the panel.
I have an example as well, Terry. I have a hypothetical situation where the provider does a chest x-ray for every patient, an annual chest x-ray. And lo and behold, it can be paid with the diagnosis of hypertension, which, again, I'm not a clinical person, but I have a really hard time understanding how hypertension is diagnosed on a still picture. But the answer that I was given was, it gets it paid. And then with that picture, we can use it for screening purposes to see if there's any arteriosclerosis or, anything else going on. And my answer to them is, but screenings are not covered. So you're manipulating a diagnosis that you're not really using. You're fishing. Exactly. You're not really going to be treating that hypertension off of that chest x-ray, are you? But it gets it paid, is what I hear. And we have to remember that there's a fine line between what may be considered good medicine and what a payer has agreed to pay for. So sometimes a patient might have to pay for a chest x-ray if you really feel like that is something that they need to have, because trying to monkey it to get it paid, well, that always leads to, the big F word.
I have doctors that are trying to add diabetes and renal disease or chronic kidney failure because they want to incorporate a dietitian or nutritionist into their practice, and Medicare only pays for medical nutritional therapy for 3 diagnoses. And I said, wait, this is a bariatric general surgery practice. The patient's just obese. And they said, I know, but that doesn't get paid. I'm like, so you're giving them renal disease, you're giving them diabetes, and they said, but that's a covered diagnosis.
Merry Christmas.
Oh my gosh, that follows the patient. Try to let that patient get, health insurance in the future with being labeled. I have a practice years ago, but still, they actually had to shut down because of this. They weren't getting paid for their breast biopsies when they put unspecified, so they gave the patient cancer. They even gave it to them in situ, and I was like, why did you do that? And then because only the 174 is paid. That was when we were in ICD-9. And I was just like, I'm speechless. I don't understand the thought process there.
Yeah, I'm doing a review right now, actually. And all of these patients are ending up with unspecified anxiety. And it's not really being centered in the history at all. It's not any sort of specified anxiety, general anxiety disorder, or something like that. One of the things that I try to relate to providers about unspecified diagnosis codes is this is when you get to the end of the road and nothing more specific makes sense or is applicable to this person. And I see that with depression and anxiety all the time, not just in psychiatric, but in primary care. And the question I ask is, well, you've been treating this person for years. They are, an established patient to the practice. You're managing the clinicals of this circumstance. it's almost like I want to ask, like, aren't you at least curious about what kind of depression it is? Like, I'm curious, like rather than just saying this is unspecified depression after umpteen number of years, and then the next thing becomes, well, it's depression unspecified, it's anxiety unspecified. But when I write the diagnosis treatment for the anxiety, I just basically say, like, see above. And then I say, well, is this depression with anxiety? And that's, just one example. But I think the point is that a couple of things, like, I think these unspecified diagnosis codes sometimes find their way in, or it's speculative on my part, but it feels like, well, this is a rationale to get something paid. But it also, I feel like I want to ask the provider in a lot of situations beyond laterality, like, you're the one who's working this up. You're the one who's seeing this patient on a revolving basis. Is this really, after all this time, the most specified diagnosis we have?
So let me ask a question real quick for any of you who want to answer this. How do social determinants of health impact remunerations for physician clients?
So for me, I mean, this is obviously one of the newer areas under the guidelines, and I look for a couple of things. I look for, the way I describe it is, it's like the two-step, right? Like, step one is, what is the social determinant of health? Step two is, how specifically does it impact the patient's ability to follow a treatment plan, their ability to receive care? How does it impact the potential impacts of what's happening? And there could be look, it's not for me to second guess some of these reasons when they're valid. If a patient if the patient has to receive a medication that requires them to take it 3 times a day because they can't afford the one that they take one time a day, and consequently they're missing doses, and they're having negative lab find, or I'll say negative is the wrong word, but if they're having, like, adverse lab impacts, or adverse health impacts, like, that sort of is a textbook social determinant of health, right? Like, the one I always remember, I had worked with a pediatric endocrinology group. We had a lot of, that group was not it was in a not great economic area. A lot of parents were either not engaged or they were working night shifts. And so there really wasn't a lot of supervision of these kids. And the kid's like 15, and the kid's like, well, you know what? I don't want it to be constantly having to do this, right? Like, I don't have to manage this. And one thing I knew when I was 15 is, like, my body could take a lot more blows than it could take now, right? And so when you're 15, you may be able to have a cavalier approach to managing type 1 diabetes, and you might not feel it. But the provider is constantly having to go through these things with these patients, and that's a social determinant of health, right? It's like, there's nobody there to help this kid make the right clinical decision, and that sort of is the linkage. So I'm always looking at, it has to be those two things together. Like, if you just throw in there, the patient is unemployed, well, I don't necessarily know how that's impacting the patient's ability to follow a treatment plan unless you tell me.
Yeah, I mean, there's a difference between social history and a social determinant of health, and the devil is in the details. I mean, it's not going, as Scott just mentioned, their situation is fine. I mean, it's wonderful that you document that, but you have to make a tie-in as to how all of these things impact care, and how it's going to be problematic to the patient's plan of care that's being outlined by the provider, that is going to be the real tie-in for social determinants of health. I mean, it's wonderful that the AMA added this and that CMS actually acceded to it, because it is important. But I mean, it's not important for everybody. It's a very select subset of patients that are going to be affected by this.
Well, I had that problem come up recently, and it actually was my mother, who, she lives alone, but she's great. And it's not a problem for her. It doesn't cause her to miss anything. She's taking her meds. She goes to the doctor. She does her own thing. But reviewing her records, I noticed that they put the social determinant of health of living alone. And when I press the issue, well, that raises the risk. So now we have social determinants of health, which now I have a 99214 risk, a moderate risk, coupled with 2 chronic conditions that are stable, by the way, not on medication. but that's how they were justifying the increased level of service. Wait a minute. Her living alone is totally okay, right? I think, Sean, your mom living alone is totally okay too, right? It's not.
Oh,
Let's not go there. You
bring
just
my
opened up.
mother.
You just
Yeah.
opened up a
Let's
can
not
of
bring
worms
my
there.
mother into this
Your mom and my mom
conversation.
don't live too far away from each other. That's maybe we should get them in contact. They can.
I can tell you from a
Yes,
personal
because
level,
it would stop her from sending me 27 text messages a day about getting her Ubers to go everywhere and getting her Instacart to bring her food. And why haven't I been down there since I moved her there last October? And I said, why do I have to come down there? I hear from you 27 times a day. I know what's going on. It's okay. We're
Yeah.
good. But
I can
no,
tell you
thanks
from
for-
a
thanks-
personal point of
Thanks
view,
for
if
creating
my,
my anxiety. Go ahead, Paul.
yeah, I can tell you from a personal point of view, if my wife lived alone, that would actually significantly lower her risk. So, it's it's in the eye of the beholder there. I mean, again, you got to explain it.
But also, people are
but
being
let me ask this
labeled.
question.
People are being labeled that they don't want to be labeled. I mean, I saw one, and I think I might have mentioned it before, but there was one where it was a pediatric practice, and the kid came in just for vaccines and to talk about things, and he happened to mention that he was mad at his teacher or something, and they put a social determinant of health that he was depressed at school. The parents almost had a fit because then they started getting stuff from their insurers saying, here's some depression counseling, here's where you need to send him, we pay for this. And the parents like, what are you talking about? And they're like, oh, we got something from your provider. And they're like, and now my child is labeled as having a mental health disorder. And he was just there basically for a sports physical. So people have to realize that social determinants of health, they're for data mining so that the government can determine where the axis of care and lack of treatment is, is prevalent. And why is it? Is it because, what Scott said? Is it because the patient has a financial hardship? Is it homelessness? Is it focused on a certain age, ethnicity, certain group, and certain populations? It's not to bump up your codes. And that's what really I love the concept, but I don't like the overutilization of it.
So I guess for me, because I don't really, I don't deal with social determinants of health, right? At least in the federal criminal cases that I've been a part of, right? Thus far. My question, because I'm somewhat ignorant to the impact of these codes, right? So my understanding is that these social determinants of health are supposed to paint a picture of a patient being in a socioeconomically deprived situation that negatively impacts the quality of their care, that raises the complexity level because they're non-compliant and the physician has to do more work, so thus they desire more reimbursement. I mean,
That's part of it.
I'm
That's
being
one of them.
sincere and genuine when I ask this. I need somebody to please help me understand this a little bit better.
So
go ahead.
Sorry. So a couple of things there. One is we're moving social determinants of health into value-based reimbursement. We're going to see this now in the coming years where those particular socioeconomic situations are going to eventually get value on that risk adjustment side. And let me tell you that that's just the tip of the iceberg. Okay. And from the risk perspective, and then we have the fee for service perspective, where those social determinants of health, like you said, Sean, they're really looking at that as this is a more challenging patient because they're homeless or they live alone or they're having some other financial crisis, homeless instability, things of that nature. So I think that they opened up something to identify an area of potential risk, but for us, that's on the other side of the coin on that reimbursement side. I think they've kind of really unleashed something that we're going to have to be on top of.
I agree.
Fair enough. Scott, you were about to say something?
Yeah, the one thing I always think about with the social determinants of health is it is a moderate risk item. And so, a number of the cases I look at, even when they're trying to use it, are probably moderate cases anyway for various reasons. The patient may have multiple chronic diseases and they're on medications. So it doesn't always necessarily raise the service level risk. And beyond that, I would just share Christine's concerns. It does open a Pandora's box in some ways. It particularly when it's misapplied in this way where the provider hears half of a story and says, well, I'm just going to write this down, right? I'm just going to put in, okay, this is a poor person, or whatever that may be, but it doesn't have anything to do with their care. And I think the risk to the provider, the one thing I wanted to clarify, the way I look at it sometimes, is the risk of the provider is not necessarily that the patient is sicker today. The patient may just require a higher level of intensity of ongoing management to remain stable for one of these reasons, right? Like the patient may be harder to get on the schedule. The patient may be harder to treat. The patient may have, parents who are not in accord on the right treatment plan, right? So there are these things that when they're leveled or centered in that way, the patient may not necessarily be sicker today, but the patient may be more complex over the long term to help remain stable or healthy or something like that. So, there's a number of factors for it. I don't feel like it should be raising levels of service an extraordinarily large amount of time, because a lot of times when I see it, they're moderate complexity cases anyway. But I agree with what everybody has said, even in the comments, about this idea that we shouldn't just be sticking things in there that either are going to reverberate with the patient in some other way, right? Like, oh, the patient has passive suicidal ideation. Like, no, the patient does not, right? And it's just what becomes one of those things that I think we have to use some care when we're diagnosing patients and putting these things in the notes.
Very well said. All right. So since we've been talking about diagnosis codes, our last topic of the day in the last few minutes that we have are our dear friends at United Health Group. And once again, their behavior has led to allegations by the U.S. Department of Labor that UHG denied thousands of patients payments for emergency room services and urinary drug screens. Paul, I swear we just cannot get away from these UDTs. It seems like every case that's coming down the pike for us in the last year is tied to UDT somehow. So basically what's going on is the lawsuit indicates that UMR, a third-party administrator, and United Health, the subsidiary, denied claims based on diagnosis codes and failed to comply with the requirements of the Affordable Care Act and the Department of Labor claims procedures regulations. So what happened is UMR denied all urinary drug screenings from August of 2015 to August of 2018 when it should have determined whether a claim was medically necessary, which violated the Employee Retirement Income Security Act, better known as ERISA. And the lawsuit further alleges from August of 18 to the present, UMR allowed some urinary screenings if it was done in an emergency setting, but changed its denial code again in October of 2019. And the explanation of benefits did not comply with the ACA. So the lawsuit says that UMR changed its urinary drug screening process in August of 2018 because 98% of the claims that they were denying were being overturned upon appeal.
You want to hear something that gets a little bit scarier about the UDT issue is that beginning today, I just got an email over the weekend from Quest Diagnostics that says they're going to be taking level 1 NCCI edits and applying them to drug screenings. And now we have, I don't know how many of you are aware of this, but as of July 1st, 2023, we have an NCCI edit that is trying to be put in place where presumptive and definitive can't be done on the same date. So if you are submitting something through Quest, and perhaps My belief is that most pain management clinics, any respectable pain management clinic, is going to be doing at the very least a presumptive in-house, with a urine dip. But if you're sending a presumptive, if you're sending a definitive test out, and that's billed based on CMS regulation by date of collection, and it's the same as the presumptive test, it's first come, first serve, and somebody's going to get denied. And it's about to get ugly, 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 as if it couldn't get any uglier. I just wrote an appeal letter today for another provider who's being looked at by an SIU for urine drug screenings. Again, pain management clinic. What's an opioid epidemic without testing? It's crazy.
It is. It's frightening. And, the states, Paul, you and I have had this conversation. The states tend to be more liberal in what the requirements are and the amount of testing that can actually be performed, which the carriers have become extremely limited and very strict on what they're allowing for payment.
Most definitely true. I mean, in the case of West Virginia, up to 24 tests a year, which is 4 times as many as allowed by LCD in that region.
Yeah, unbelievable. All right, let me go around the horn real quick, and I'm going to start with Terry Fletcher. Any final thoughts on our podcast for our listeners today?
No, I think we covered all of our topics this week. I actually like that. So hope everyone is staying cool wherever you are. I know it's hot out there.
Absolutely. Christine Hall.
Well, I just want to remind everybody that you can't remember what you had for lunch 6 months ago, then you can't document today what you did 6 months ago. It's very rare that we're going to remember that unless it was your birthday or something,
Very good point. Scott Kraft.
I just echoing some of the things I said before. I think one of the things I love about the 2021 guidelines is they really just kind of cleared the decks of a lot of the extraneous nonsense we used to put in notes or have to tell doctors to put in notes. But the goal was not to create new, more brief extraneous nonsense. Just document the things that you're actually doing. Be direct in your treatment plans, be specific in your diagnosis codes, and stop trying to cut as many corners on these guidelines, because it is going to come back to haunt you, I think.
And Paul, any final thoughts?
Just 12 years, 8 months, and 22 days at a maximum until I retire, barring the winning Mega Millions ticket tomorrow. So got to play to win.
Wait, if you win, what's the new timeline?
12
tomorrow.
minutes, 8 seconds, and 22 tenths.
Got it.
Okay. So with that said, I'd like to thank Terry for not yelling at me at all today. It was a wonderful episode. To Scott, Paul, and Christine, great to have you guys. As always, Stephanie, we are thinking about you and Jesse, hoping everything turns out well for you guys. And to each and every single one of you, thank you so much for tuning in, logging on, and hanging out with us. It was an excellent discussion, great topics, wonderful panel. Terry and I will be back tomorrow with, I am certain, what will be a great and lively topic discussion. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.